This recording will go over esophageal tumors. Although esophageal tumors can be benign, most are malignant and the majority arise from the epithelium. Esophageal tumors grow rapidly because there is no serosal layer to limit their extension. Because the esophageal mucosa is richly supplied with lymph tissue, there is early spread of tumors to the lymph nodes. In most cases, the tumor is large and well established on diagnosis. Primary risk factors associated with the development of esophageal cancer are smoking and obesity. Increased abdominal pressure associated with obesity is linked to reflux and Barrett's esophagus. Both conditions can contribute to changes in cellular structure in the esophagus, increasing the potential for adenocarcinoma of the esophagus. In addition to these primary risk factors, malnutrition, untreated GERD, and excessive alcohol intake are also associated with esophageal cancer. Barrett's esophagus results from exposure to acid and pepsin, which causes changes in the tissue. The tissue undergoes dysplasia and ultimately becomes cancerous. Diets high in foods that are high in nitrate are associated with the development of squamous cell carcinoma, as well as diets that chronically are deficient in fresh fruits and vegetables. When obtaining a patient history, assess for risk factors related to the development or symptoms of esophageal cancer, such as gender, history of alcohol consumption, tobacco use, dietary habits, and other esophageal problems. Cancer of the esophagus is a silent tumor in its early stages with few observable signs. By the time the tumor causes symptoms, it usually has spread extensively. Please review Chart 54-7 for key features of esophageal tumors. A definitive diagnosis of esophageal cancer is made with fine needle aspiration. Barium swallow and EGDs may also be done to assess the patient. A PET scan can be used to identify metastatic disease with more accuracy than a CT scan. The most specific common problem for patients with esophageal cancer is potential for compromised nutrition due to impaired swallowing and possible metastasis. Interventions to maintain or improve nutrition status focus on treatments that remove or shrink the obstructive tumor. Methods to reduce the effects of treatment that can impact nutrition are also a priority. Surgery is the most definitive intervention for esophageal cancer. The treatment of esophageal cancer often involves a combination of therapies. One therapy is nutritional and swallowing therapy. The purpose of nutrition therapy is to administer food and fluids to support the patient who is malnourished or at high risk for becoming malnourished. We want to make sure that a screening assessment is done and the patient is weighed daily before breakfast on the same scale each day. Teach the patient to remain upright for several hours after meals and avoid laying completely flat. Remind the UAP and other healthcare members to keep the head of the bed elevated at least 30 degrees or more to prevent reflux. Semi-soft foods and thickened liquids are preferred. Liquid nutritional supplements are used between feedings to increase caloric intake. But enteral feedings or tube feedings may be needed temporarily when dysphagia is severe. In patients with complete esophageal obstruction or a life-threatening fistula, the surgeon may create a gastrostomy or jejunostomy for feeding. Collaborate with a speech-language pathologist to assist the patient with oral exercises to improve swallowing, and with the OT occupational therapist for feeding therapy. Ask the patient to suck on a lollipop to enhance tongue strength. Teach him or her to reach for food particles on the lips or chin using the tongue. In preparation for swallowing, remind the patient to position the head forward in a forward flexion with chin tucked. Then, tell him or her to place food in the back of the mouth. Monitor the patient for sealing of lips and tongue movements while eating. Check for pocketing of food in the cheeks after swallowing. Radiation may be used alone or in combination with chemotherapy and targeted therapies. For photodynamic therapy, the patient is injected with a light-sensitive drug that collects in cancer cells. 2 days after the injection, a fiber optic probe with a light at the tip is threaded into the esophagus through an endoscope. The light activates the photoprin or the light-sensitive drug, destroying only cancer cells. After photodynamic therapy, advise the patient to avoid sun exposure for 1 to 3 months. Sunglasses and protective clothing need to be used. The patient may experience chest pain secondary to tissue damage and will require pain relief with opioid analgesics for a small time. Teach the patient to follow a clear diet for 3 to 5 days after the procedure, and warn the patient that tissue particles may release from the tumor site and may be present in the sputum. Esophageal dilation may be performed as necessary throughout the course of the disease to achieve temporary but immediate relief of dysphagia. Dilators are used to tear soft tissue to widen the esophageal lumen. In most cases, malignant tumors can be dilated safely, but perforation remains a significant risk. Large metal stents may be used to keep the esophagus open for longer periods. A stent covered with graft material can be used to seal a perforation. Bacteremia can also occur. To reduce the risk for endocarditis, antibiotics are given. Prolonged stent embedment into benign esophageal tissue can cause ulceration, bleeding, fistula, dysphagia, and the formation of a new stricture if the stent is not removed. When patients are not candidates for surgery or the tumor is too large to remove surgically, laser therapy or electrocoagulation using endoscopy may be performed as a palliative measure. Both of these methods destroy some cancer cells and reduce tumor size to improve swallowing.